Good afternoon and welcome to today's webinar on getting back into the swing, avoiding shoulder surgery with Regenexx treatments. I'm Dr. Burgum with Regenexx Des Moines. Um, we will be going over common orthopedic conditions with your shoulder that we can treat using your own cells from your blood or from your bone marrow to help you avoid surgery. I have two other panelists along with me today, Danielle, Laura, and Natalie Cataldo, and they are from our patient education and scheduling team. And so they will be available to answer any questions you may have about getting lined up with an appointment or other things regarding the schedule. And so if you have questions regarding scheduling and things of that nature, feel free to put messages either in the Q&A or the chat box. And if you do connect with Danielle or Natalie and are interested in setting up a scheduled appointment, they will reach out to you later today or tomorrow. And at the end, I will put up a slide that shows all of our contact information as well, in case you want to call them and if you cannot make a connection today. So Regenexx, we are where stem cells were injected. The first use of human stem cells for orthopedic conditions in the United States was done at our initial Regenexx clinic at the Centennial Schultz Clinic in 2005. And since then, our network of Regenexx clinics has expanded to over 140 affiliate clinics. So I just want to back up. I'm a physician. I'm board certified in sports medicine, and I have extensive training in interventional orthobiologics. And so the first thing we'll talk about is what is interventional orthobiologics, and then I'll go over the different treatments that we do, the different cell types that we use for your treatments, and I'll discuss common shoulder issues that we can help you avoid surgery on. So what is interventional orthobiologics? Well, that's a fairly new medical specialty, probably come to fruition in the last 15 or 20 years. And the core tenets are that we use injectates, things that we inject into your body that promote the healing of bone, tendons, ligaments, muscle, or cartilage. And we do not use things like steroids, which can help reduce pain in the short term, but in the long term, steroid injections like cortisone injections actually accelerate your arthritis and accelerate tendon injuries. So everything that we do is meant to promote healing, to stimulate and further enhance your body's own innate healing. The other tenet is with interventional orthobiologics is we don't do blind injections. We don't feel and just inject it into the area. We use precision guided injections using high resolution ultrasound and high resolution real-time X-ray called fluoroscopy. So there are doctors all over the country, from family medicine to pediatrics, even internal medicine, sports medicine, who will do very simple injections, meaning they'll put an injection into your joint. And actually, like most orthopedic surgeons, if they do any type of injection, it's a simple non-guided injection where they'll inject something into a joint. That represents about 95% of the US physicians. Now, maybe 4% of physicians will do interventional orthopedics, meaning you're using guidance to inject steroids or lubricant medicines like hyaluronic acid into the joint. But the more advanced injection techniques will not just focus on just putting it into the joint, but looking at the entire structure. So there, like I said, there are maybe 4% of you as physicians will use some type of guidance to go into the joint. However, interventional orthobiologics, that means we are using your own cells to inject into your joint, but it's much more than just putting a shot into the joint. So I look at the entire structure of your joint, not just the cartilage. Like for instance, if someone is being seen for shoulder arthritis, I'm not just only focusing on the cartilage wear and breakdown, but I'm looking at the entire stability of your shoulder, all the ligaments and structures that stabilize your shoulder, the rotator cuff muscles and tendons that move the shoulder, the lip of cartilage along the socket called the labrum. And so an injection by an interventional orthobiologic physician like myself, which represents about 1% of the physicians, these types of procedures are much more involved and much more thorough. And if you look at the diagrams on that I'm pulling up, you can see the first lower one, the hip. It's not just a hip injection that a patient might get, but there's numerous support structures around it. Or similarly in the knee, you can inject into the joint, but there's also the patella tendon, the quadriceps tendon, all the support ligaments, the ACL, anterior cruciate ligament. We can actually treat that tears of that. And in the shoulder, you've got rotator cuff tendons. You've got the smaller joint on the top of your shoulder where your collarbone attaches, called the AC joint. You have the main glenohumeral joint. And numerous supporting ligaments that I often will inject in patients who have a lax shoulder. If their shoulder just doesn't feel stable, we can increase that stability by injecting things like the glenohumeral ligaments, the superior, middle, inferior, numerous ligaments. And all these are done with precision guidance. So at Regenexx here, we are very different from other, quote, stem cell clinics. First off, all procedures, all evaluations are done by physicians, not mid-level practitioners. And we have to be highly trained in the field before even becoming a Regenexx affiliate. Once we are in the Regenexx network, there's a significant amount of continuing education that we do to stay abreast of all the latest changes in both injection techniques and regenerative medicine breakthroughs. I mentioned before, all injections are done using guidance. Your cells, be it bone marrow extract, which contains stem cells and other healing cells, or your blood to get platelets out of your blood, are processed in a clean room on site. We have a sterile laboratory and state-of-the-art technology, and not just using some simple bedside device that can be purchased from a device manufacturer. We're supported by a multi-million-dollar research lab and facility in Colorado, and they also guide us on our periodic tests of our facility to make sure that our laboratories is sterile, and that everyone who's processing any of the patient's blood products are following our strict criteria for technique and sterility. There also is a fellowship training program in Colorado for high intensity training in orthobiologics. And now there are over 140 sites worldwide. Our network is expanding. And we have a big benefit of being treated by a Regenexx physician such as myself is we have the world's largest orthopedic outcomes registry. So what does that mean? Well, we track how well all our procedures work and how long they work. And this all started in 2005. So we now have 20 years of outcomes data. So what does that mean? Well, before you have a procedure done, before you have any injection done, we ask you to fill out a survey that takes 5, maybe up to 10 minutes, a survey that asks questions specific to your joint, in this case, the shoulder. So questions such as, how is this limiting your life? How much pain are you having? What are you needing to do to, as far as taking medicines or things to just to perform your daily activities? After the procedure, you'll get similar surveys emailed to you. Initially, every couple months, it starts spacing out to every 3, then every 6 months. And at the 2-year point, the surveys space out to every year for up to 20 years. So as a result, we have the world's largest outcome database. And we use that. I use that when I see you in the office to help determine how good of a candidate you are for a procedure. It all starts with the data that's from 20 years of research. I mean, of outcomes following our different procedures, and then I look at that to get a baseline, and then I look at you. I look at your own healing environment that's in your body, and to determine maybe you're a little better or maybe a little worse candidate than the average candidacy rating from our outcomes database. But it's all customized. We use that data as a baseline, and then I look at your own health, your own overall holistic status of your body. So, for example, I look at maybe you have some medications that might negatively impact your outcome a little bit, or maybe you're taking some supplements that actually help your outcome. So we just spend a lot of time looking at how can we maximize your outcomes? What can we do to improve your diet, to decrease chronic inflammation in your body? What sorts of things can you do for stress reduction? Because if you're under stress and you're under physiologic stress or emotional stress, our bodies don't heal as well. So in your evaluation, when you come in and I examine your shoulder and look at the joints above and below, like your wrist and your elbow and your neck, you spend a lot of time looking at, well, what's your diet like? How can we help to make you a better candidate to respond even better to the procedure? And what other things can we do to help? But that all stems off of this enormous database. And so we also, and I can also pull out my own data and see how my patients are doing. And I'll go over some of those numbers in a little bit. So getting back to interventional orthobiologics, here are some pictures. On the left here, shows an ultrasound suite with our ultrasound machine, and this shows what it would look like doing an ultrasound procedure. On the right is that is fluoroscopy. That's the real-time X-ray. And that's actually a bone augmentation procedure that we'll talk about in a little bit. So what sorts of things do we see? Well, I see all different types of shoulder problems, but probably the most common ones would be the rotator cuff, the muscles that rotate and stabilize your shoulder and help you lift your arm, and shoulder arthritis. But so the rotator cuff is a group of 4 muscles that come off of the shoulder blade. So on the picture here, this is looking from the back side, looking at someone's shoulder. And the main ones here are the supraspinatus muscle up here and the infraspinatus. And then the third one on the back side is teres minor, which is very rarely torn. The most common damaged tendon problems come from the supraspinatus and the infraspinatus. And then the fourth one comes from the undersurface of your shoulder blade called subscapularis. That one helps rotate your arm in, like reaching behind your back. The other ones rotate your arm outwards. And then right in that same area, in between the supraspinatus and the subscapularis, there's a groove in the bone. We have a tendon, the biceps tendon, the long head of the biceps comes up through here and attaches onto the socket at the labrum. So that's what those structures look like. Here's a picture showing a tear. So this is under the shoulder blade. So that's subscapularis, and this shows what a tear looks like. So tendons, imagine tendons as sort of like ropes. They can be kind of roundish and with fibers all packed together. They can be a little more flattened out, like on here. So when patients have a tear, there's different degrees of tears. So you can have a tear where it may go through a partial width, like this one here. That's a subscapularis partial width tear. It could go all the way across, but maybe not go all the way through the full depth. So that would be like a full width but partial depth tear. Or you can have a complete rupture where it's torn all the way across and all the way through the depth. And that's what on the top here, this shows a rupture with retraction of the tendon backwards towards the joint. And so on MRI, we use MRI, we get for most patients, we'll get an MRI of their shoulder. And in some cases, I can see everything that I want with ultrasound, but we use X-ray imaging and MRI imaging and ultrasound imaging to analyze your shoulder. And so these are some pictures here that show what a rotator cuff tear looks like. On above here, those are partial thickness tears, and on the bottom, that's a complete tear, and it's retracted. So back in this area, if we're looking at the top picture, the darker gray is muscle, and tendon gets more compact and it becomes more light colored. But this area here where it's all white, that's fluid, that's joint swelling or bursa swelling. Just like on the bottom, here's muscle back here, it turns into tendon, and the tendon should be continuous. It shouldn't be wavy like that. That's a sign that you have a rupture. So with ultrasound, this view is a little blurry, but this is a picture of the supraspinatus tendon. So bone on ultrasound is bright white. The dark here is it shows up dark just because the sound waves bounce off of the bone. So you can't see into the bone with ultrasound, but you can see the structures above the bone very well. So this is what a normal tendon looks like, except for this dark area here. That is what we call an intrasubstance tear. So it's torn in the middle of the fibers, but not on the surface and not on the underside. So if someone had a tear like this and they saw an orthopedic surgeon, they'd be really reluctant to try to fix that, because when they go in and look with an arthroscope, they can see the top surface, but they can't see into the middle of the tendon. With ultrasound, we can. And so we can actually guide an injection right into that area. So this is another view. This is one of my patients, similar story. It's a tear in the middle of the tendon. Now this view is looking at it at a 90 degrees, 90 degrees rotated compared to this one. So now imagine the tendon fibers are coming straight at us out of the picture here. And so on ultrasound, dark is a tear. On the top is intact tendon, and on the bottom is intact tendon. So other things you may have heard of is a labrum tear, or you may have heard the term SLAP, S-L-A-P, superior labrum, anterior to posterior. So labrum tears a labrum is the lip of cartilage that goes along the socket that helps to increase the surface area to give you more stability. And people can get tears of that labrum. And on the right here, this shows fluoroscopy images with a thin needle being guided right to the edge of the labrum. Then that dark sort of smudge is contrast dye that tells us that we inject to show that we're in the labrum. And then after that, I would inject either the bone marrow extract or the platelets. So why will interventional orthobiologics help replace elective surgery? Well, it's less invasive. We use skinny needles, we use precision guidance. There aren't big cuts in the skin. You don't have to go under general anesthesia. Patients recover much quicker. You can use your arm the day of the injury, I'm sorry, the day of the procedure, and we guide you through progressing your activities through physical therapy. But a big thing is you get to keep your parts. You're not losing your ball and socket and having a total joint replacement, or and you also keep your mechanics, your biomechanics. You preserve those mechanics, and we work to help improve those mechanics with the guidance of physical therapy. Whenever patients have a procedure, part of the treatment is always going through increasing your range of motion and strength and stability afterwards with physical therapy, and we send them guidelines, our protocols on how quickly to advance your activities after a procedure. So we can treat many types of rotator cuff tears. My earlier picture showed you partial tears and full thickness tears. So you can have a full thickness tear where the ends of the tendon fibers are still close to where they normally would be, so they haven't retracted far away. And then there are full thickness tears with retraction that, uh, and the kind of the cutoff point is the retraction, is the gap between the tear and the normal attachment site more than a centimeter. So partial tears and full thickness tears that aren't retracted, we can treat those. If it's retracted more than a centimeter, we say you are a poor candidate. Uh, you may have other tendons in the rotator cuff that are torn that may have less than a 1 centimeter retraction, but if it's greater than 1 centimeter, we'd say even with bone marrow extract with stem cells in it, you would be a poor candidate for a procedure. So some of when I mentioned the different cells or different types of treatments that we use, most commonly used would be your body's platelets from your blood. And the terminology for using that is called PRP, platelet-rich plasma. So that is where we draw your blood and extract the platelets from your blood and use concentrated platelets to help heal your body. The platelets themselves do not turn into new tissue. They don't turn into cartilage or tendon or ligaments. What they do is the platelets release many, many different growth factors that other cells in the area take up and start growing from. The platelets do this once they become activated, and they become activated when they come into contact with connective tissue like tendons, ligaments, or cartilage. In Regenexx, we can concentrate or make the dose or the strength of that PRP many times higher with our state-of-the-art lab and state-of-the-art orthoascent processing device than can be done by other clinics. So we can get the dosage to the proper strength. And I say that because it's been well studied that the strength or the concentration of your platelets that's used in PRP has a direct effect on your outcome. It has been shown that as we get older, let's say, for example, if we're treating an arthritic joint, if we're putting platelets in the joint, the older we are, the higher the dose of platelets we need to become active. Similarly for tendon issues and ligament issues. So younger people don't need as many platelets, and the older we are, the more platelets we need. So we need to concentrate them. We need to get more platelets in a small volume, and we can do that. Every patient gets a customized treatment plan of what the concentration of platelets are and where they're going to be, as opposed to other clinics that there's clinics all around the area. They'll say, yep, we can do PRP. Well, they're limited because they buy a device from a device manufacturer that they run the blood through to make platelet-rich plasma. And they're limited to the concentration that they can make from that. Some of the really good devices can concentrate your platelets maybe to 6 or 7 times your blood concentration. A lot of the poorer ones may concentrate your platelets to 2, maybe 3 times your blood concentration. Well, what does that mean? Well, when we look at treating arthritis versus tendon issues, we have to concentrate those platelets about twice the strength as what we do for ligaments or tendons. So if patients are under the age of 30, the research has shown that the maximum concentration that you would need would be maybe up to seven times your blood concentration. So for young people, the best platelet-rich plasma kits on the market, other than Regenexx processing, would be beneficial if you're under age 30. Now, a lot of people with shoulder and knee and orthopedic conditions are over the age 30. So as we get older, let's say you're into your 50s or 60s, into the joint, you'd want to get that concentration up to 20 times your blood concentration. And for the tendons and ligaments, 10 times your concentration. And we do that routinely. So when we use platelets, we'll use that for platelet-rich plasma for tendon and ligament issues or for more mild arthritis. Another thing we use is called platelet lysate. So what is that? That's a technique, a laboratory processing technique that we use to release the platelet growth factors. Um, by processing it in the lab, and then those growth factors are available immediately, and it's think of it as like an immediate release PRP injection. Because platelets, when they're injected, when we do a normal PRP injection, platelets, and even in your body, when you get an injury, the platelets arrive and they start releasing growth factors slowly over a course of 10 to 14 days. Platelet lysate, we release all those growth factors immediately. So we'll often use platelet lysate when we're injecting around nerves, like in the spine, or for carpal tunnel in the wrist, or irritated nerves. But we'll often mix in platelet lysate with our platelet-rich plasma to give you some immediate action and some slower release action. So I mentioned platelets. They have numerous growth factors. We're not going to go into all the details of this picture here, but this shows all the different growth factors. Well, not all, the most common growth factors, the biggest volume of growth factors that are released from platelets. And it includes growth factors that stimulate tendon healing, growth healing, cartilage healing, new blood vessel growth into damaged tissue, insulin-like growth factor, which helps with collagen synthesis or making the connective tissue stronger. But some of the big things that are important, there are growth factors that stimulate your own stem cells in the area, and they stimulate them to become more active and to actually migrate towards the platelets. And there's another one called transforming growth factor, beta, that stimulates your stem cells to transform or to become their final cell type. So the platelets actually stimulate your stem cells, and that's a major action that we take advantage of. So patients will often ask, well, if platelets are part of my blood, why don't they go there anyway? And the issue is that tendons and ligaments and cartilage do not have a vigorous blood supply. So it's hard for platelets to actually get to damaged rotator cuff tendons and ligaments. Whereas if you get a cut in your skin, our skin, we have a great blood supply, and platelets get there immediately and help stop the bleeding and form a clot and a scab. And but when you have injuries to your tendons and ligaments, the blood supply isn't as great. So we take your platelets, concentrate them into PRP, or take your bone marrow and extract the healing cells from the bone marrow and guide them directly to the injured area. And so let's talk about stem cells. So the true term for these are called MSCs, mesenchymal stem cells. And so we extract we get these cells from the bone marrow from the backside of your pelvis. And in that area, when we extract the bone marrow, it's called bone marrow aspirate, or BMA. Your bone marrow will have red cells, white cells, platelets, plasma, stem cells, and many other healing cells that direct the repair of damaged tissue, and are more potent than platelets. And so we can also concentrate the bone marrow extract much higher than other clinics can do. So a lot of patients are worried, they have anxiety, or they've heard stories about patients who've had a bone marrow biopsy, let's say a family member or a friend who's had cancer, and they're concerned about pain from that. And so it's kind of daunting, and you know, if you think about it, someone's going into the bone and extracting bone marrow. I can see how you'd be uncomfortable with that, but on the bright side, we do these. I mean, I did 2 today, and patients tolerate this very well. And there's several reasons why, but it's actually well tolerated, and it has to do with our technique and how we help control the pain. So on the far right here, so when we do a bone marrow draw, it is a surgical technique. We use complete surgical scrub, surgical drapes on the patient. I'm in a surgical gown. mask. And on the right here, this shows what it looks like as someone is having a bone marrow draw. Bone marrow looks like blood, and it's a little, maybe a little thicker than blood. In the middle here, this device is a trocar. It's a bone trocar. That's what we use to kind of bore into the bone and extract the bone marrow. So on the end here, it's a little different color on this one. That end piece is removable, and when you pull that out, it takes out the sharp tip. So it's called a stylet. So imagine there a needle within a needle, and on the inner needle has the sharp diamond tip end that can bore into the bone. And so when we get into the bone, I extract that and put a syringe, attach a syringe on the end, and then slowly extract the bone marrow. Um, so we call that a BMA. I mentioned it's sterile technique. And so the bone itself has sensory fibers on the surface. So I anesthetize that with a local anesthetic. We also start an IV and give you some sedation. So you're awake, but you're sleepy. You might even fall asleep, but you're not under general anesthesia. But you're sedated, and we can also put pain medicines through the IV as needed. And when I do a bone marrow draw, I start with the lowest possible dose of a pain medicine. And actually, I use that more because to help when I poke through the skin with the needle to anesthetize the skin and going down to the bone marrow. I mean, going down to the surface of the bone. But actually, when I'm going into the bone and drawing the bone marrow out, most patients can't even tell what I'm doing. So we really don't need a lot of pain medicine for the bone marrow draw. And while I'm doing it on every patient, I'll ask them, as I'm extracting the bone marrow, aspirating it through the syringe, I'll ask patients, tell me what you're feeling right now. And about 1 out of 20 will say, that kind of hurts. Otherwise, patients say, I can't tell, or they'll say, it's kind of a weird sensation. Um, and so these diagrams here show what this is on the left here. This is the position that you lie on. You're lying on your stomach with your lower back and upper gluteal region exposed. Over on the right here, this kind of shows a drawing of the needle with the syringe going in. And in the middle here, this is a zoomed in picture. So we have a thin layer of hard bone, and then inside it's like a honeycomb. And this is where we go in with this thick needle, the trocar. And the drawing here shows the area on the back side of your pelvis called the iliac crest. We extract it from this region. So, and I go in to several locations to get the bone marrow aspirate. So when patients have a bone marrow biopsy, or a lot of other clinics that do interventional orthobiologics, they'll go in like on this picture on the far right, kind of straight down in from the top and go deep into the bone marrow and draw it all and take a lot of bone marrow aspirate out at once. And that hurts. The reason why it hurts is because we have pressure sensors in the marrow cavity. The drawback with that is apart from it being more painful, is when you draw it all from one location like that, you get a much lower cell count of live healing cells. When we do a bone marrow draw, every patient, we do a count of their total live nucleated cells and record that in your chart. And the technique that we do at Regenexx clinics, and we're teaching, there are other facilities around the world that know that this is the best way as well. The technique that we do is we come into the bone marrow, like in this picture above. I draw out just a little bit of bone marrow, 5 milliliters, which is like a 1/6 of an ounce. Then I advance that trocar half a centimeter deeper, draw a little bit more, go half a centimeter deeper, draw a little bit more. Then back out of the bone and redirect the needle into another site and repeat that at multiple sites. So the reason for that is you get the much higher live cell count. You get the most number of live cells by doing it that way. It takes a little longer, but we get much higher cell counts, and that's what we want. We want to get as many cells for you as possible. But as a side effect, you don't have that big pressure change. So this just kind of is a drawing that shows all the different types of cells that we get out of your bone marrow. There's sometimes we'll use platelets from the bone marrow to make platelet-rich plasma. There's granulocytes, there's different stem cells and other cells. So the stem cells are actually a small component of the bone marrow aspirate. There are other healing cells in there as well. So like just with my own registry data, we've got 341 patients for shoulder procedures going back over the last 5 years. Um, and and overall, patients rate their improvement at 39% by 1 month after the procedure, 58% by 3 months, and 71% at 1 year. And that's maintained out to 5 years at 79%. So on the far right, this dash, it's a disability score. That's a standardized orthopedics pain and disability function score that is used for all different surgeries or carpal tunnel syndrome or elbow surgery or shoulder surgery to assess how disabled is your arm or shoulder. How much is this affecting your life? So a high score is worse, a low score is better. So on my patients, then their initial scores would have showing that they're roughly 35% disabled with that arm. At 3 months, their scores drop down to 18.6%. At 1 year, 13.9%, and at 5 years, 11.4%. So again, a lower number is better. So just to back out and look, and how can we help you? What can we do to help with shoulder problems? Well, we can treat up to moderately severe shoulder arthritis to help avoid shoulder replacement. If patients have severe shoulder arthritis, you become less of a good candidate, provided you're actually a better candidate if you have fairly good maintained range of motion and if you don't have a large bone spur coming off the ball. Patients who have severe arthritis and just cannot move that shoulder at all, and if they have a large bone spur, we say our data shows you're not a good candidate. You have a low chance of getting long-term relief. We'd say go get your shoulder replaced. But if you have mild to moderate or even moderately severe arthritis without very large bone spurs that might get in the way of moving your shoulder, we can use bone marrow extract and treat very advanced shoulder arthritis. We can treat rotator cuff tears, and I mentioned the labrum tears, which usually go hand in hand with arthritis. If the ball and socket is wearing down, the lip of cartilage called the labrum generally is wearing down as well. It's pretty rare to have an isolated labrum tear unless you're a young person that's recently had shoulder trauma. But we treat all those structures. So one final thing I want to address is stem cell hype. So if you go on the internet and you search stem cell treatments or stem cells, you'll get tons of websites, books, clinics purporting to treat everything under the sun, and the biggest abuse that we see is clinics providing amniotic or placental or cord tissue stem cell injections, and they charge a lot for these. And I think part of the marketing pitch is you don't have to have a bone marrow biopsy. We can buy it and inject it in you, but do not do that. And the reason is those products have been tested not only at Regenexx research labs but multiple facilities around the world. I just have a published study of looking at these tissues, and they have no live cells in them. So if you think about this, if you're getting cells from another person, it has to be sterilized. And so the process of sterilizing it essentially kills all the cells. There are some growth factors. I remember how I mentioned platelets release growth factors when they become activated. There are some growth factors in these amniotic tissue products, but that's been analyzed as well. And there are fewer growth factors in those products than if you just took your blood and injected blood into the area. So it's actually regulated under the FDA as a dead tissue product. So we don't use anyone that other's tissue to inject into your body. We draw your blood or we draw your bone marrow. It stays on site, goes to our lab, we process it, we extract the cells and concentrate the cells, and we inject it into your body that very same day. So it never, everything that we do uses your own cells. So avoid the hype of the amniotic tissue or Wharton's jelly or any of that, and use only your own cells. So if you're thinking about a procedure, you'd want to ask, okay, where do the cells come from? Are they my cells? What is the sterility of your process? Is your processing tested by third parties like ours? We periodically we do swabs of our laboratory and make sure that it's sterile. So I mentioned earlier that Natalie and Danielle are available. If you have questions, I should have reminded you halfway through. You can send them a message on the chat or preferably in the Q&A. They can work with you if you're interested in getting in for an evaluation. I just want to let you know when I do an evaluation, it's not like a typical orthopedic clinic visit, which may last only 5 minutes. My evaluations are usually 60 to 90 minutes. We do a thorough evaluation, and like I mentioned, we look at your diet and all different things surrounding your overall health to help give you the best chances for success. Then after that visit, if you're going down the pathway towards scheduling a procedure, you then would meet with our patient care coordinator, Carrie Julin, and she spends a good half hour or more with more educational handouts and pamphlets and kind of reiterating some of the recommendations that I've made during my visit. So it's not a quick visit, it's a thorough evaluation because we want to make sure that we are giving you the best possible care. So right now, if you have any questions, I can take questions directly, or if you have questions for our scheduling team. And while we're doing that, here's the contact information. If you call this number, you can reach our scheduling team. Our website has lots of information where you can also, if you go to the website, if you don't want to call someone right now or tomorrow, if you go to the website, there's a form that you can fill out that asks you, am I a candidate? And it'll take down information that gets directly to our scheduling team. And then they would reach out to you and contact you. Let's see. And I'm looking at the Q&A. I see something there, but I am not. The other thing is if you have questions, you can put them in the chat, and that pops up on mine as well. Natalie or Danielle, do you have any?
Nope, I think there was that one question about insurance that I just answered for that particular person. So we do take some insurances for the consultation. So when we connect with you guys, we'll reach out just to see if you have any additional questions or would like to schedule. And at that time, we can get what insurance you have and let you know, if we take that for the initial consultation, but we really do take most of them. So that should be able to help for the consult and follow-up visits and things like that. So we can discuss that with you, but sorry, I kind of grabbed that one before you answered it, Dr. Berger.
Oh, that's right.
But yeah.
And there's a question about for BMA or PRP, is it one or the other? And that's a great question. So when I do your evaluation and I look at what is your degree of injury or breakdown, do you have advanced arthritis or mild arthritis? Do you have a low grade tendon tear or a high grade tear or a full thickness tear? So we start with the outcomes database to say, well, for let's say you have moderate shoulder arthritis, our data would say you're maybe just a fair candidate for platelets, which means you've got a 50 to 70% chance of getting long-term relief, but you're a good candidate for bone marrow. So we'd say, well, you're a better candidate for bone marrow, but you're not a bad candidate for platelets. If you're a fair candidate, that means you might need a second procedure. You might need a repeat platelet procedure, maybe 2 to 3 months down the road. And sometimes for patients who are more on the fair to poor spectrum that are doing platelets, you might need a third procedure. Um, we don't just automatically book that. I follow up with you. We do either a phone or an in-person follow-up at 6 weeks and a in-person follow-up at 3 months. But so in your office visit, we determine what are your different treatment options. Does it include bone marrow or platelets or both? So when we're doing a bone marrow procedure, that generally is actually a 3-step procedure. There's one injection day where I'm injecting a substance called prolotherapy. It doesn't use your own cells. It uses sterile water and diluted medical sugar water called dextrose. We inject that into the tissues to cause some localized irritation and inflammation. When we do that, local cells around that detect that inflammation, and healing cells start migrating towards that injection site. So that we do that to sort of prime the pump 2 to 7 days before we do your bone marrow procedure. Then we do the bone marrow extract, and at that day, we use the bone marrow stem cell extract for the most severe areas. Like for instance, if you have significant joint arthritis, but we use platelet-rich plasma for any supporting structures like joint ligaments that are lax, or low-grade rotator cuff tears. We put platelet-rich plasma into those structures on the same day that we do the bone marrow procedure. Then 2 to 7 days after the bone marrow procedure, we do a platelet-rich plasma booster. So let's say, for example, we're treating the main shoulder joint arthritis. 2 to 7 days after your bone marrow extract injection, you come on in, we do a blood draw, and we make super high concentrated platelet-rich plasma and inject it back into the joint. And we do that to take advantage of those growth factors that I mentioned that platelets release. There are growth factors that directly stimulate stem cells and stimulate your stem cells to convert, to transform into their final cell type. So we take advantage of that, and we inject the platelet-rich plasma to give those stem cells that we injected 2 to 7 days earlier a boost, to give them a bump and more activation. So everyone's treatment is customized, and so like there'll be some patients with a higher grade rotator cuff tear and bone marrow, and shoulder arthritis, and I'd put bone marrow extract into both of those areas. So we come up with a custom plan, and that's why everyone's amount of blood draw and the amount of bone marrow that we have to use is customized. So that was a question. Do you treat a combination of issues with one treatment? Yes, we don't just do an injection in your rotator cuff and then say, okay, come on back in a month and we'll inject your joint. We address the entire structure. So everything that needs to be addressed in that shoulder joint. Some people, for example, they'll come in and I examine their shoulder and it is stable. There's no laxity in the shoulder. Their ligaments are great, but the rotator cuff tendons have problems and they've got arthritis. Those patients, we treat those tendons and the joints. Now, there might be some people who come in and maybe they've had a shoulder dislocation in the past. All the support ligaments are lax and weak, and maybe they've got mild arthritis, but a high-grade rotator cuff tear. Well, then we'd say, your best bet would be to use bone marrow extract with stem cells for the rotator cuff tear, and then platelet-rich plasma in all these loose ligaments, and then maybe platelet-rich plasma in the joint. Now, let's say every time I do a bone marrow draw, we don't just draw as much as we can. We want to draw. We estimate how much are we going to need, and draw the appropriate amount of bone marrow. So, for example, if I draw 60 cc's of bone marrow out of the patient's hip, I expect to get 3 to 5 ml of the layer of all the healing cells. The rest is blood and plasma. Sometimes patients will have a little bit more. Sometimes patients will have a little bit less. So we have, when we get it back from the lab, then I look at those numbers again and I look at, okay, where can I put everything? Where can I, how do we optimize your treatment? And oftentimes we'll have more bone marrow than we need. And I'll say, hey, we can put this, instead of doing platelets in your low-grade rotator cuff tears, we're going to put the stem cells in it. So whatever we get, we try to maximize. Similarly, if you're set up for a platelet-rich plasma injection, and in the processing, our lab was able to say, hey, we were able to make more platelet-rich plasma at a higher concentration. I'd say then I'd use that in that joint and maybe put more than what I expected, or I'll say, hey, we're treating your shoulder. How's your elbow? How's your wrist? If we have extra platelet plasma or extra bone marrow, we do not throw it away. We'll look and say, is there anything else? If we have extra, we're going to use it. So another question is, does any treatment impact bone spurs? Really, no, it does. With bone spurs, develop for different reasons. The bone spurs around arthritic joints come off from the side of the joint, and those are in response to the extra forces on the joint, and you really can't remove those. Now, that's not that bad of a thing, because spurs do not cause pain. So when people say, oh, I've got my elbow hurts, I must have a bone spur. Bone spurs are the result of the underlying problem, not the cause of the problem. And in your, for instance, let's say in a knee joint, when patients are getting more advanced arthritis, you'll start developing spurs coming off to the sides. That's your body's response to try to stabilize your joint, to give you more stability in your joint. And so going in and just shaving off those bone spurs is actually counterproductive. So I guess the bottom line is to remember, spurs are not the cause of a problem, they're the result of a problem. Let's see. Do we have any other questions? So this webinar is recorded. You'll get a link of it emailed to you. You can share it with friends, and it will be available on our website. And like I said, we have, oops, I just went past it. We have the contact information. You can call our scheduling team, and you can also contact us through the website. So thank you for coming. I hope this was helpful, and I hope it gave you hope if you're looking at surgery. We definitely can help you avoid surgery for many of the shoulder problems. So with that, have a good night, and expect to see another webinar probably in the next 3 to 4 months. It may be on hips, it may be on ankles. Well, I haven't decided what, but I try to do one about it once a month. So if there's nothing else, hold on. Let's see the slide deck. Oh, I see. Yeah. So you'll get the recording, but not the slides. Okay. All right. Cheryl, do we receive the slide deck? And I think Natalie said the slide deck is not sent, just the recording. So yeah, you don't get my PowerPoint slides, but you do get the recording of it. So, all right, well, have a great night and enjoy the summer.